Welcome to World Health News, your credible source for the best and authentic health news all over the world. I'm your host, Dr. Yavuz Selim Silay, physician, entrepreneur, and venture architect, delighted to be with you again. Today, I have very interesting 5 news around the world about health that I would like to share with you. The first one is about artificial intelligence. New Europe-wide report explores the impact of artificial intelligence on healthcare practitioners. Our second news is about very interesting point that I would like to share is about Bayer Pharmaceutical. Heart Association puts halt to Bayer's giant displays of baby aspirin. Our third news is about HIV. A simple method to prevent HIV greatly increases viral suppression in South Africa and Uganda. Our fourth news is about a very important point about continuity of care. Continuity of care related improvements in patient health outcomes have been achieved. Our fifth news is about a very important public health approach. A public health approach to prevention and as well as treatment of firearm violence that I would like to share. Ladies and gentlemen, let's get to our news. The first one is about the new Europe-wide report exploring the impact of artificial intelligence on healthcare practitioners.
The workforce of the future means a number of things. One is the work fundamentally is changing. So just like we want to serve patients differently in the future and they expect to have more of a consumer type approach, consumerized approach in the way that they engage with their provider, it's very similar when it comes to the employee. The employee has a certain expectation, and I think we've got to take into consideration as we're driving digital and automation into the workforce, it's not about just more technology, it's about smart technology. It's about making my job more enjoyable and more satisfactory so I can serve the patient. When we think about what's going on in the healthcare industry that's causing this need to reimagine and re-engineer the work, there is our reality as an industry that we are a little bit behind. Right? There are many things in the day-to-day that are things that frustrate physicians and patients and their families and the administrators that have gone on for decades. So, for example, take things like the way that clinicians document. The need to document has been, a need forever. In the old days, right, it was, paper charts and whatnot, and some are still on paper today. That need to go with that electronic medical record, have things documented real time, being able to drive charge capture real time, that is much more of something that is required today that was not the case in the past. What it's also allowing us to do is take leaders in industry and outside of industry to design together and address those challenges in more of a systems view and a holistic view that says, how could we design to delight the patient or the employee?
A very interesting new report from EIT Health and McKinsey & Company has exposed an urgent need to attract, educate, and train a generation of data literate healthcare professionals and upskilling the current workforce if we are truly and fully realize the transformative potential of AI, known as artificial intelligence. This report, which I reviewed carefully, is based on a body of research exploring the impact of artificial intelligence on the future of European healthcare and its workforce. Of course, it's about Europe, but it can be implemented to everywhere else. That's why I want to share this with you. Additionally, it highlights the need to define new organizational models and skill sets that healthcare professionals will need to support the adoption and scaling of artificial intelligence, and outlines the new types of talent that will need to be attracted. The report found that basic digital skills, biomedical and data science, data analysis, and the fundamentals of genomics will be critical if AI and machine learning is to penetrate healthcare services. These subjects are rarely taught alongside the traditional clinical sciences in our medical schools systematically at this time. So, through no fault of their own, today's healthcare workforce is simply not yet equipped for the adoption of AI. We all know that. George Fernandez Garcia, the Director of Innovation, EIT Health, and co-author of the report, mentioned the incentives for healthcare systems to embrace these changes are clear. The World Health Organization estimates that by 2030, the world will be short of almost 10 million doctors, nurses, and midwives, which adds further urgency to address the challenge of already overburdened health systems. Supporting the widespread adoption and scaling of artificial intelligence could help elevate resource capacity shortfalls both now and in the future. For example, by streamlining or even eliminating administrative tasks, which can occupy anything between 20 and 80% of a healthcare professional's time. At present, diagnostics is the main application of AI within healthcare. However, in the next 5 to 10 years, healthcare professionals expect clinical decision-making to top the list of applications according to this interesting survey. George also mentions that being at the forefront of healthcare innovation in Europe, they are increasing and they are able to see an increasing number of tangible, impactful, and exciting artificial intelligence solutions created. However, they have to couple the generation of new technology that can relieve some of the pressure on healthcare services with the ability for it to be integrated into care delivery. Now is the time, ladies and gentlemen, for all of us to address these gaps so that the entire world, including Europe and Africa, does not fall behind in the application of AI, known as artificial intelligence. So, of course, talent is very important. Besides upskilling, better involvement of healthcare professionals in the early stages of AI development was also identified as a key need. Currently, 44% of those surveyed, chosen for their interest in healthcare innovation and AI, had never been involved in the development or deployment of an AI solution. Dr. Angela Spataro, partner at McKinsey & Company, and report also a report of the that prepared the report. She also is mentioning that artificial intelligence has enormous potential to improve productivity and efficiency in health systems and make them more sustainable. But more importantly, it has the potential to deliver better health outcomes for patients. It can do so in many ways, from enabling more preventive care to allowing healthcare practitioners to spend more time on direct patient care. This joint report provides a good guidance for decision makers to define their level of aspiration on artificial intelligence and develop and implement the right approach for their organization or health system. During interviews with decision makers, urgency in developing and scaling up training was emphasized, as was the suggestion that national health systems should work together with healthcare professionals, academia, and industry in order to support healthcare providers, in particular those who are not large enough to deliver such programs alone. Starting from our medical schools, nursing schools, and supportive medicine professionals, these programs have to be delivered. They also emphasize the importance of ensuring artificial intelligence is ethical, transparent, and trustworthy. This very important report, which included a survey of 175 people on the front line of healthcare delivery and interviews with 62 decision makers, was complemented by macroeconomic analysis of the future of work for European healthcare systems from the work of the McKinsey Global Institute, MGI. It provides a unique view on the state of play and prospects of AI for healthcare in Europe, covering areas including strengthening data quality, governance, security, and interoperability, implementing a robust change management strategy, addressing issues around regulation, policymaking, and liability, redefining funding and reimbursement models, which is important for all of the countries around the world for sustaining healthcare systems, and criteria for investment, and designing how disciplines can work better together to improve our quality in the system. This was a very interesting news that I wanted to share. Our second interesting news is about the giant Bayer Pharmaceutical.
News on aspirin and whether you should be taking it to reduce your risk of heart attack or stroke. There are new guidelines tonight from the American Heart Association. And so let's get right to Dr. Jen Ashton, because Jen's been tracking this all day. And Jen, you and I both know there are a lot of people watching the news tonight who've been taking that daily dose of aspirin to try to reduce heart attack or stroke. But for folks who are 70 or older. This is a major reversal.
Oh, it's big news, David, in the world of cardiology. The new guidelines say if you're 70 and older, you should not take an aspirin to prevent a first heart attack or stroke because the risk of bleeding is thought to be better than any potential benefit.
But if you've had the stroke before or a heart attack before, you should keep going.
Absolutely. These new guidelines do not apply to people who have already had a heart attack or stroke. They should not stop their aspirin.
And what about the age group, say, from 40 to 70? If they've been taking a daily dose of aspirin, what do you do there?
That's where it's a little tricky. If you're between 40 and 70 and you're at high risk for heart disease, but low risk for bleeding, it might be an option, so you should talk to your doctor.
All right, Dr. Jen Ashton, trying to clear up the confusion tonight for us. We always appreciate it.
Bayer Pharmaceutical is a very important company and doing a really good job globally. You all know baby aspirin, and Heart Association puts halt to Bayer's giant displays of baby aspirin. The large red and white bins at Walmart pharmacies across the United States, in bold, all caps type, approximately every 40 seconds, an American will have a heart attack. Inside the 3-foot-tall cartons, adorned with the American Heart Association and Bayer logos, were dozens of boxes of low-dose baby aspirin for Bayer Pharmaceutical. The implication was that everyone could reduce their heart attack risk by taking a baby aspirin. But recent studies, ladies and gentlemen, have found that that's not the case. In fact, the American Heart Association says that all the aspirin can help people with previous heart attacks or strokes. Its risks generally outweigh the benefits for others. After Kaiser Health News inquired about the marketing bins, the Heart Association in late February said it is having Bayer, one of its major donors, pull them from Walmart, although the campaign was due to wrap up by the end of the month anyway. But 10 days later, a reporter shopping at a Walmart in Florida, United States, found a bin still on display. The American Heart Association told Bayer to take down displays like this one at a Walmart in Jupiter, Florida, because it could falsely suggest that baby aspirin could reduce heart attack risk. So, about a quarter of Walmart around the United States, all of these stores, which is very common, nationwide displayed the bins, the association said. This was a misstep, said Suzanne Grant, a spokesperson for the American Heart Association. It was a human error on their end. Aspirin helps keep the blood from clotting, so there is less chance that blockages will form in key heart arteries. For years, it was generally recommended as an option for healthy individuals to prevent heart attacks. But it also can lead to stomach bleeding, a serious side effect, and a number of studies have raised questions about the safety of aspirin used for people without cardiovascular disease. Last year, after 3 new studies were published on the issue, the American Heart Association joined other medical groups advising against aspirin therapy unless a doctor recommends it. The United States Preventive Services Task Force, an expert panel that makes recommendations on medical care, is re-examining its guidelines, which advise low-dose aspirin for people ages 50 to 59 who have a risk of cardiovascular disease and no history of bleeding problems. It also has noted that individuals aged 60 to 69 at risk of heart disease may want to consider the therapy, but it should be used selectively. Evidence for other age groups is inconclusive, the task force says. Grant said that the association approved the marketing bins without including precise language, explaining that people need to talk to a doctor before taking aspirin regularly. That language is printed in smaller, tiny type on the Bayer baby aspirin packaging. The bins promoted the Heart Association's Life is Why We Give, a fundraising effort. Bayer is a financial supporter of the campaign. Dr. Eduardo Sanchez, the chief medical officer for the prevention at the American Heart Association, said the bins could have given people the wrong impression and led to more liberal use of baby aspirin. So their position is that the aspirin should be used sparingly, if at all, in people who have not had a heart attack or stroke, Sanchez said. Ladies and gentlemen, so this is a very important point that You need to talk to your doctor whenever you are actually making a decision. Of course, we are empowered with our own decisions, but always consult your doctor. Our third news is about HIV. Simple method to prevent HIV greatly increases viral suppression in South Africa and Uganda, which is a great news. Also in parts of Africa, where the rate of HIV is high, researchers found that using mobile vans to dispense antiretroviral treatment and other care greatly increased viral suppression. Researchers enrolled 1,315 people living with HIV and not on antiretroviral treatment in a nearly 3-year study in South Africa and Uganda using mobile vans to dispense treatment. This very important randomized controlled trial conducted between May 2016 and March 2019 found that viral suppression was 74% compared to 63% for those seen in a clinic. The results were presented March 9 at the virtual conference on retroviruses and opportunistic infections, CROI. With millions needing treatment and not getting it, this community-based intervention could do a lot to help stop the spread of HIV. Ruan Barnabas, the lead author and associate professor of global health at the University of Washington School of Medicine, Barnabas said the convenience of the vans in the community made getting care much easier. People who needed ART could start in an hour and get treatment for a year without ever needing to go to a clinic. So the vans, paid for by the Bill and Melinda Gates Foundation, operated daily from 11 a.m. to 8 p.m. in 5 locations. This study was conducted in rural and peri-urban areas of high and medium HIV prevalence in South Africa and Uganda. In South Africa, the study was conducted in 11 communities. In Umugondlovu district, KwaZulu-Natal, with a population HIV rate of 36%. Overall, an estimated 7.7 million South Africans are living with HIV, and about 3 million are not unfortunately getting treatment, according to data from UNAIDS in 2019. In Uganda, the study was conducted in 6 communities in the Shima district, with a population HIV rate of 11%. Overall, an estimated 1.4 people are living with HIV in Uganda, and about 380,000 are not receiving treatment at the moment, ladies and gentlemen. This is according to UNAIDS 2019 data. Both communities in South Africa and Uganda have public clinics that offered access to ART and no cost, but are characterized by high unemployment and low per capita income, below $2 a day, United States dollar. So ladies and gentlemen, there has to be more efforts, not just in South Africa and Uganda, but across Africa, fighting HIV and as well as other non-communicable diseases. Ladies and gentlemen, our fourth news is about the continuity of care related to improvements in patient health outcomes. When I looked at it, it was very interesting. Research shows higher continuity of care, meaning a care team cooperatively involved in ongoing healthcare is better for health outcomes. But can there be too much of a good thing? New research in the Informs journal, Manufacturing and Service Operations Management, finds the answer as yes. Continuity of care is related to improvements in inpatient visits, length of stay, and readmission rates. But the data show outcomes improve and then decline in increasing continuity of care, suggesting that there may be value in having multiple providers. This study, Maintaining Continuity in Service, an empirical examination of primary care physicians conducted by Vishal Ahuja of Southern Methodist University, Carlos Alvarez of Texas Tech University, and Bradley Stats of University of North Carolina at Chapel Hill, looked at 300,000 patients from the Veterans Health Administration over an 11-year period. They focused on patients who suffer from diabetes or kidney disease, a major complication of diabetes, as we all know. Through the researchers' work and prior literature, the consensus is that continuity of care creates an opportunity for learning with repeated interactions. The service provider gains important knowledge about the patient's situation. So these exchanges may improve the efficiency of subsequent interactions, yielding both productivity and quality benefits, but the relationship may not be so straightforward. Variety may also prove some beneficial effect. With too many repeated interactions, it is possible that a service provider may grow complacent and miss information. A new provider may provide a fresh look at an existing problem. Therefore, Vishal Ahuja, professor in the Cox School of Business at SMU, the data proved continuity of care is especially important for patients suffering from more serious conditions because it provides even more operational value for those complex patients, which results in a greater opportunity for improvement from continuity. At the highest levels of continuity of care, the outcomes actually grow worse. It is possible to have too much of a good thing. So focusing continuity on sicker patients can result in saving millions of dollars annually, continued Ahuja. So it is necessary to understand where continuity matters most and where perhaps it is less vital. I want to thank Institute for Operations, Research and Management Sciences for this very important article. I believe there will be more publications where we will share with our viewers. My last news is about a very important public health approach to prevention and treatment of firearm violence. While firearm violence is a major public health challenge around the globe, including the United States, it has often been considered a law enforcement issue with only law enforcement solutions. An article by the University of Pennsylvania researchers advises that treating firearm violence as a disease and taking a public health approach to prevention and treatment can help reduce its harms. Key to achieving that goal will be to overcome legislative mandates around research funding which have hampered investigators from establishing careers, studying firearm violence, and building a body of evidence. An important step this year is the allocation of $25 million in the federal budget to NIH and CDC, specifically targeted to study of the firearm violence. Federal funding around firearm violence research lags far behind the burden of disease, says Teresa Richmond, and Andrea B. Laporte, professor of nursing and associate dean for research and innovation at the University of Pennsylvania School of Nursing, Penn Nursing. The consequences of firearm violence are broad and deep for individuals, families, and communities. Both Kaufman and Richmond are affiliated with the Penn Injury Service Center, which brings together university, community, and government partners around injury and violence intervention programs. Therefore, it is critical care providers that can analyze the intersections among individuals, firearms, and environments across the continuum of care, and how public health research can design, test, and implement effective interventions at the environmental, policy, technology, and individual levels to prevent firearm violence. Ladies and gentlemen, healthcare providers are perfectly positioned to change the current political diatribe from pro-gun, anti-gun, to how we can systematically study approaches and implement evidence to reduce injury and death, as we do with other diseases. So, Beyond Band-Aids for Bullet Holes is another article which talks about firearm violence as a public health priority, has been published in the journal Critical Care Medicine. Recently, Richmond presented the William Shoemaker Honorary Lecture on the impact of gun violence on public health during the Society of Critical Care Medicine's 49th Annual Critical Care Congress in Orlando, Florida. And you can also view a recording of the presentation right now here.
Since 1990, the number of gun deaths worldwide has reached 6.5 million. 3/4 of gun deaths occur in just 15 countries. Latin America is home to some of the world's most violent countries by murder rate. El Salvador, Venezuela, and Guatemala are the top 3 countries for deaths caused by guns per population. These Latin American countries are marred by corruption, organized crime, and a dysfunctional criminal justice system that further fuels the problem. The availability of guns in the United States is another concern for these countries. An estimated 200,000 guns a year that were first sold in the United States are smuggled over the southern border and used in violent crimes in Latin America and the Caribbean. In the United States, The constitutional right to bear arms has led to looser regulations and easier access to firearms. This contributes to the 30,000 men, women and children who are killed with guns each year. Mass shootings attract the headlines, but in fact these make up only 0.2% of gun deaths. 60% of gun-related deaths are in fact suicide. America's suicide rate increased by 25% between 1999 and 2015, with nearly 45,000 taking their own lives in 2015 alone. Half of these suicides were carried out with guns. Though guns aren't the most common method of suicide, they are the most lethal. Other wealthy countries have far lower rates of gun violence. In Japan, if you want to own a gun, you must pass a written exam and a shooting range test, alongside a series of mental health, drug and criminal record tests. It has virtually eradicated gun crime. After a mass shooting in 1996, Australia introduced an effective buyback scheme of firearms. In the 20 years following the ban, there was an accelerated decline in total gun deaths. But in America, the House of Representatives has not voted on a single measure to prevent gun violence. And in some states, such as Texas, where students at public colleges can now carry concealed handguns, the law has actually loosened. Easy access to firearms will continue to be the main driver of America's gun deaths.
Ladies and gentlemen, I want to thank you for your time and your trust on World Health News. I'm your host, Dr. Yavuz Selim Sulay. Stay tuned. I'm really excited to continue to share the best news and the most credible news around the world in health. Take care and all the best.